Good morning, everyone. Welcome to GI Grand Rounds. I have the distinct pleasure of introducing Dr. Connie Wang, who I've had the great pleasure of working with many times over weekends, holidays, and various inpatient services, much to my education. She is a practicing gastroenterologist here at UCSF, where she specializes in caring for patients with gastrointestinal motility disorders, including esophageal motility concerns, gastroparesis, GERD, and functional GI disorders. Any fellow who's worked with Dr. Wang on the inpatient rounds can attest to her very nuanced and thoughtful approach to some of our really most uniquely challenging and delicate cases in the hospital. Prior to joining us here at UCSF, Dr. Wang earned her BA from UC Berkeley and then completed her medical degree, residency in internal medicine, gastroenterology, and then advanced transplant hepatology fellowship at UCSF. Dr. Wang belongs to the American College of Gastroenterology, the American Gastroenterological Association, and American Neurogastroenterological and Motility Society. It's my great delight to pass this off now to Dr. Connie Wang for what will certainly be a high-yield talk on functional GI disorders, which I've personally enjoyed very much in the past. So take it away.
Awesome. Thank you so much, Molly, for that very, very kind introduction. It's good to see everybody today. I'm just going to make a quick plea. If you can turn on your cameras, that would be amazing just to see all your faces. I know it's early in the morning, but good to see you. So like Molly mentioned, so today my focus is going to be talking about what we previously would call functional gastrointestinal GI disorders. I do want to credit Dan Selvig, who was one of our former attendees at UCSF, and sadly left us about a year or so ago now. And so he used to give this talk, which is, again, super high yield, one of my favorite talks as a fellow. And I always learned so much. So hopefully I'll be able to continue that tradition. So today we'll kind of talk about a general approach to, again, these functional gastrointestinal disorders. I really want to just actually to start off to highlight, I should change the title of this talk, and it should be really about the approach to disorders of gut-brain interaction. And so we've made this shift now from calling these spectrum diseases from functional GI diseases more to disorders of gut-brain interaction, or DGBI, as this is kind of less like a stigmatizing kind of terminology. And so we'll kind of go into that a little bit more in detail. I have no disclosures. So for our objectives today, again, to review the diagnostic evaluation, in particular around chronic abdominal pain, as well as particularly abdominal pain-related disorders, the gut-brain interaction, kind of briefly review the management of irritable bowel syndrome and functional dyspepsia as two of the most common diseases that you might see within the DGBI, and then hopefully I'll have time to also kind of just review, recognize common belching and bloating disorders that can come up in the clinic. So why is this important? Why is this something that we all should kind of care about or learn about? So you'll see that DGBIs are very, very common. And so really globally, but this is kind of a more representative study that was done of two large surveys in the US population. So one study was collected in 2015 with about 2,000 patients, and the other study was done in 2017 with similarly about 2,000 patients. And they were all asked to complete the Rome-4 survey, which is how we diagnose patients with DGBI. And so these are all kind of validated self-report questionnaires. And you'll see on the left-hand side kind of here, the general, prevalence of any DGBI is about 36 to 40% among their entire population that they surveyed. And then if you break that down a little bit further, you can kind of categorize each of the DGBI by different organ systems. So the most common was kind of more in the bowel or colon area with up to about 30% of patients. And then second, that was followed by gastroduodenal DGBI, and then esophageal, and then lastly, anorectal. And one, kind of interesting point I just want to point out is that we've also seen there's been a rise in both the prevalence and the burden of DGBI has really significantly increased since the COVID-19 pandemic, so since 2019. So this was a study that, again, used the Rome-4 diagnostic questionnaire. And this was conducted actually in the UK as well as in the US. So they looked at pre-pandemic in 2017, and then they repeated the same survey in 2023, so kind of post-pandemic or the worst of the times. And they found that the overall DGBI prevalence here has kind of increased. Sorry, the numbers are a little bit small, but kind of has increased by odds ratio of 1.2 during that time period. And that you see that kind of most dramatic rise, actually, if you look at the subtypes of the certain types of the DGBI, in particular was for functional dyspepsia here. So we saw a more dramatic increase in functional dyspepsia as well as in the prevalence rates of IBS as well. Some of the factors that associated with this increase in DGBI were female sex, younger age, comorbidities of anxiety, depression, those who had more COVID-19 infections, if they had GI symptoms during COVID, and then if they were experiencing long COVID as well. So kind of getting back to this change in terminology. So, how do we really define functional GI disorders? And again, we're shifting away now from calling these diseases functional GI disorders now towards the term of disorders of gut-brain interaction. So I'll probably end up using this a little bit interchangeably during my talk, but try to be consistent with using DGBI terminology as well. So some classic examples, that I alluded to will be irritable bowel syndrome or IBS, as well as functional dyspepsia, functional constipation, et cetera. And this is really defined using a symptom criteria rather than biomarkers. And so what I mean by this is we use, again, the Rome 4 framework and diagnostic criteria using purely just symptoms alone. And we'll kind of go into more details about, when we talk about IBS and functional dyspepsia. But that's really how we diagnose people, is based on the symptom criteria and not relying on necessarily any diagnostic testing or biomarkers. And so I bring this up more just to say that when you're talking to patients, it's really important to kind of give them this positive diagnosis based on their symptoms alone. And we'll go into it as well, some limited diagnostic testing, but really we shouldn't think about DGBI as a diagnosis of exclusion, but rather more of a positive diagnosis that you can give to patients. And some of the important factors to keep in mind when you're kind of going into your history taking with the patients is that there can be biologic, psychological, and social elements, even coming back into childhood, that can really contribute to the development of this disease. So if you look at the Rome 4 criteria, so this is actually developed in 2016, you'll see that there are a total of 33 disorders, at least for adult DGBI, of various types and subtypes. And this goes all the way from kind of head to toe. So you can come up with with various different disorders, starting with like belching and globus disorders kind of start at more the head, but moving your way downwards, you'll get to this, gastroduodenal, so you have functional heartburn, functional dyspepsia, cyclic vomiting, more to the colon, you'll get the IBS, functional bloating, centrally mediated abdominal pain. You can even get anorectal pain disorders. So we'll kind of, again, I'll focus today mainly on the irritable bowel syndrome and the functional dyspepsia, but just kind of be aware there are these many other types and subtypes as well. And then also, they're still coming up with the Rome 5 criteria, but I believe that should be coming out probably in 2026 now, so should be updated soon. So to talk a little bit about the physiology of DGBI, so, again, I think a common kind of misconception is that people think, oh, this is just something that there's no physiologic explanation. It's just all going on in my head. But really, there have been plenty of studies now that have demonstrated there are, true changes, physiological changes that are occurring in the body that can really lead to the development of the DGBI. So starting with your motility disturbance, so abnormal motility of the GI gut can, understandably lead to symptoms of nausea, vomiting, diarrhea, et cetera. And they found that in healthy subjects more so, and then compared to patients with DGBI, that really a strong emotion or environmental stress can really impact the motility within these patients during these studies. They've also found that this can develop with an altered visceral hypersensitivity, so that in patients who have DGBI, when they tested using a balloon distension of the bowel, that they have a much lower pain threshold compared to healthy controls. So again, there's something about how they're perceiving pain that's changed as well. Similarly, there's alterations in the mucosal and in immune function and immune dysregulation that can happen. A kind of a classic example we tell patients about is when we talk about post-infectious irritable bowel syndrome. So something about that GI infection has really altered the mucosal immune regulation of the gut, and then can lead to these subsequent symptoms as well. And similarly, you can have a change in altered gut microbiota. This can also be impacted by food, diet, et cetera, as well. They've seen changes in this as well as altered CNS processing. So kind of all of this can really lead to development of the DGBI from these various factors. Um, so zooming back and kind of let's say what's the general approach I have. So in a patient who has who's coming in to see you in clinic, let's say with chronic, longstanding, undiagnosed or unclear etiology of a chronic abdominal pain, this is kind of a helpful framework I found to really help me understand or kind of get a better sense of what conditions I might want to think about, but in particular for a DGBI or not. So kind of seeing if whether or not there's kind of a more diffuse versus a localized pain. So we think maybe there's more diffuse, kind of non-specific abdominal pain, depending on any maybe potentially certain risk factors. So there's really nothing that you found, then maybe think about CAPS or the centrally mediated abdominal pain syndrome. So there's not really any associated symptoms otherwise, and there's no other, pre-existing pain disorder that might explain it. So this is really just when patients are coming in with a kind of chronic abdominal pain. If, let's say, they have a history of chronic opioid use, then something else to consider is narcotic bowel syndrome. And then classically, usually the history is that the pain has been worsening despite increasing doses of the abdominal of opiate use. Um, so switching over to, let's say they have more localized pain within the abdomen, what then? So a really helpful physical exam that you can do is the Carnot sign. And we'll talk a little bit more about how to perform this. So if the Carnot sign is negative, let's say, then think about, again, maybe one of the GBIs, classic, commonly like the functional dyspepsia or IBS. If it's positive, then this suggests there's something about the abdominal weight wall pain that's eliciting the pain. And some common or classic examples you might think of are like anterior cutaneous nerve entrapment syndrome, a hernia, or maybe some complication after a surgery procedure. So what is the Carnot sign? So this really helps differentiate abdominal wall pain from more kind of deeper internal visceral pain. So how you perform this is you have the patient kind of laying on the table. You then ask them to actually identify, the location of where they're feeling that specific point in pain. Oftentimes they can kind of point with one finger where they're feeling that pain exactly. So you then want to apply pressure in that abdominal area. And then as you're applying pressure, then have the patient lift their legs up. You can also have them lift their head up as well if they're able to kind of almost do like a sit up and not a full sit up. And if it's a positive sign if the pain is either worse or remains unchanged with this abdominal tensing, that seems to indicate that the pain must be originating from the abdominal wall. It's a negative sign if the pain actually decreases with the tensing, which then suggests the pain is maybe from a deeper space. So a differential I think of, this is, I think, another helpful reference or framework for when you're seeing patients who have kind of gone through already the more typical or kind of common diagnostic workup and still maybe has this unclear or undiagnosed nonspecific abdominal pain. So these are just some more rare conditions. I won't go into as much detail, but just some helpful reference here to kind of keep in mind of how you might, of certain disease processes that you may not think of very commonly, but how to work those up if they kind of have certain factors that might raise your suspicion. So in particular, if it's the right ethnic group kind of coming from the Mediterranean background, you might think of FMF or familial Mediterranean fever. You can either send genetic testing or consider even an empiric trial colchicine. They have, this history of abdominal wall surgeries or cancers, other kind of abnormal imaging concerning for like an intra-abdominal mass or lymphadenopathy. You can consider sclerosing mesenteritis. If they are somebody who is maybe older, has a lot of risk factors for peripheral vascular disease or CED, think about chronic mesenteric ischemia and getting a CTA or a duplex ultrasound of the abdominal muscle vessels. If they kind of have multiple different organ systems that are being affected, so like flushing, tachycardia, musculoskeletal pain, hypotension, maybe think about mast cell activation syndrome, and you can check a tryptase. Similarly, if they have kind of multiple different neurovisceral symptoms in particular, so maybe there's psychiatric symptoms, muscle weakness, pain. You can think about acute intermittent porphyria and check a urine PPG at the time of the symptom onset. If they have certain symptoms that might think of kind of joint hypermobility, skin hyperextensibility, they maybe think about Ehlers-Danlos syndrome. And then if they have symptoms that particularly seem very cyclical, around the time of the menstrual cycle with dyspareunia or dyschezia, think about maybe endometriosis as well. So now I'm focusing on our irritable bowel syndrome. So how do we diagnose patients with irritable bowel syndrome? And again, this is all based on just symptoms alone. So looking at the room for diagnostic criteria here, we have some recurrent abdominal pain. So it has to occur on average at least 1 day per week within the last 6 months. And symptom onset has to have been 6 months prior. with two or more of the following. So there has to be some relation to bowel movements or defecation, and then there has to be an associated change in frequency of the stool or associated change in the form or appearance of the stool. So really kind of to make it very simple, you have to have a component of abdominal pain plus some change or abnormality with their bowel movements. So when we're thinking about the diagnosis, also just kind of keep in mind to look out for any red flag symptoms or alarm features, because if patients have alarm features, we really want to do a more extensive workup than, kind of that more basic workup I'll talk about for IBS alone. So if there's really any history of GI bleeding, if there's unintended weight loss, we think about maybe age of onset in someone who's over 50, just because there's a high risk for malignancy in these patients. So keep that in mind. If they have a family history, let's say of colon cancer, IBD, or celiac disease, if they are describing kind of progressively worsening symptoms, any nocturnal symptoms are usually atypical as well for IBS. And then if they have lab abnormalities, in particular iron deficiency anemia, all of this should prompt more extensive workup investigation. So what testing would I recommend then in somebody you think you have a high suspicion for irritable bowel syndrome? In particular, irritable bowel syndrome with diarrhea. Because the irritable bowel syndrome with constipation, you actually don't really need to do any diagnostic testing. But those who have maybe IBS mixed or with IBS diarrhea, there are a few labs I do always check for all of my patients that I want to make sure there's disease processes that are common and I don't want to miss. So those would include celiac disease, so making sure you get both the tissue transglutaminase IgA as well as the total IgA, some sort of screen for IBD, and the best one I've really found is the fecal calprotectin. And I'll go into a little bit more information about this, but you can also consider CRP as an acceptable alternative. And then if there are risk factors for chronic infection, in particular for Giardia, although to be honest, I actually check this very often for most of my patients just because I've been surprised by the number of times I picked up Giardia, then you do want to check a stool Giardia antigen or PCR. This is preferred over just the simple stool ONP. So why is the fecal calprotectin, in particular the CRP, such a useful diagnostic tool here? So this is a meta-analysis that was done of the serum and fecal biomarkers in patients with IBS symptoms and looking at how effective or how good were these biomarkers at ruling out patients with IBD. So looking at the fecal calprotectin here, they found that at a cutoff value of less than 40, this essentially confers a less than 1% risk of missing a patient with IBD. And then if you look at the CRP level here, if you look at the cutoff of less than 0.5, this similarly confers a less than 1% risk of missing a patient with IBD. So really, really helpful when these values are well within normal, that this essentially means you're very unlikely to be missing a patient with IBD, which is very reassuring. They also found, though, in the study that ESR really was of more limited value, so not something that you usually will check. So again, talking about now, when we're making the diagnosis for the patients and telling them, I believe you have irritable bowel syndrome. So how do you want to set up the framework for this with the patient? And the majority of my initial visits in patients who I have a high suspicion for irritable bowel syndrome, I'll spend a lot of time actually just kind of talking to them about the diagnosis and what this means. And I find that this is really helpful in kind of creating a more effective kind of long-term relationship, and also helpful when we're kind of talking about other therapies. I find that patients have a little bit more buy-in. So some things I really always encourage people to think about when they're talking to patients about IBS is, again, really give them a positive diagnosis. Because I think a lot of the times patients get confused, or they've seen other providers and they say, oh, they have no idea what's going on with me. They've never told me that there's something, they can't seem to find anything wrong. And so they're kind of left with this mystery, in terms of what's the cause of their symptoms, and that can be very frustrating and really hard to when you're trying to encourage them to consider certain treatments. So really, even at the first visit, I'll tell them this is what I think most likely is going on, and then it's also helpful to know, if they have maybe certain background understanding already, or maybe certain biases about irritable bowel syndrome. That's also helpful to give you a little bit more context for when you then can talk to them and kind of provide that education about irritable bowel syndrome. And I usually will give a little bit of information about the physiology of IBS, because again, we wanted them to know that this is a real disease process. We have a good understanding of why people get IBS. And then I usually will also spend a little bit of time talking about the various different approaches, both from like a dietary, behavioral, medication, and psychological perspective, so that, again, they have this framework for kind of moving forward. Sorry, should say what you should not do. on the right-hand side. So you should not do these things. So please don't give the impression that the patient's condition is undiagnosed. Again, that could be a very frustrating from the patient perspective. Try to avoid waiting to bring up the possibility or diagnosis of IBS at a later time. So again, we're really trying not to make this a diagnosis of exclusion. You want to tell them upfront. And then similar, you really I want to try to avoid trivializing or kind of minimizing the diagnosis as well for patients. So this is kind of moving towards now more management of IBS. There's a few guidelines that have come out in the last few years that I find to be really helpful. So this is one from the AGA. That's published in Gastroenterology in 2022. There's actually two, one specifically for IBS-D and then one for IBS-C management. But this is kind of a nice little diagram of kind of a step-up management of how you may approach management of these patients. And then again, kind of a little bit focused depending on whether you think they have a more IBS-D versus IBS-C. So just something you can kind of go through in more detail. The ACG also came out with a guideline on how to management of IBS, and this was published in 2021 at HAG. And they also similarly kind of categorize patients by really treating treatment towards the most predominant symptom. So categorizing people as whether they have IBS diarrhea versus the mixed type versus the constipation. So again, this is just a resource for everybody to kind of reference in the future. I'll go into a little bit more detail about some of the therapies though that we can learn about. So starting with diet. So probably the one that's been best studied and has the most data to support is the low FODMAP diet. So what this is this is a diet that's going to be low in fermentable sugars. So these are fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And again, there's been multiple studies now at this point that have shown significant reductions in global IBS symptoms with really a 50 to 70% response rate. So quite good. The key, though, with educating patients about doing the low FODMAP diet is making sure that they do it correctly. So there's 3 phases they'll start off with. So they'll start with phase 1, and this is the restriction phase. But you really want to make, so I tell patients, usually I'll have them kind of cut up all the foods, but the plan is only to do this for about 3 to 4 weeks at a time. This is not meant to be a diet that's forever, because it ends up being too restrictive and people actually will be nutritionally deficient if they stay on this long term. So I really emphasize that point. And then after that initial restriction phase, then they'll move on to phase 2, which is the reintroduction of the foods. So how I'll describe it is that they'll every few days try to reintroduce one food so that as they kind of go through that process, they may be able to identify certain food triggers. And then that kind of leads you into phase 3, where once they're kind of gone through that reintroduction phase, potentially identified a few foods that really trigger their symptoms, they can then create a more individualized diet. A couple other tips is, again, being really mindful about the potential for ARFID or avoidant restrictive food intake disorder. So when patients are really eager about this or really want to kind of stay in that restricted phase forever, I kind of start to worry about. Or in patients who maybe already I have some concerns about malnutrition or maybe are already kind of restricting their diets to a significant degree, then this is not, the low FODMAP diet is not something I generally will recommend to these patients. And then the other really helpful factor here is working with a dietitian if possible. So we're fortunate that at UCSF we do have nutrition referrals that we can provide refer patients to. But if they don't have or that option or if they have limited resources, you can always point them to the Monash University website, which has a really great detail, a lot of information. They also have a phone app now too that patients can use when they're at the grocery store, when they're kind of looking for foods. They can kind of know if they're following the diet correctly.
Honey, I have a question on
Oh
the
yeah, please,
FODMAP
yeah,
diet.
jump in.
Similar to how like EOE, you can do like the 6 for diet or like 1 with lactose. Like for patients on the low FODMAP diet who are like, absolutely not. I looked at your website. That is not going to be me. Do you have like a handful of things you're like, okay, let's just try onion, garlic, whatever. Like, do you have a modified version that you pull out of your pocket for some of these patients?
Yeah, there is like a light or modified low FODMAP version that I know some of the nutritionists will provide to patients. I don't have a good resource like offhand, but I think my general approach actually is even before I do the low FODMAP diet, I will have patients do a trial of lactose just because lactose intolerance is so common. And I didn't go into this, but I usually have them do a 2-week trial of that and then also a 2-week trial of gluten-free subsequently. And then if that, between those two, and you can also consider maybe just doing fructose as well, doing like a 2-week trial of fructose avoidance. And if that doesn't seem to help with most of the symptoms, then we kind of delve more into the low FODMAP diet. But those are kind of like my step-up approach. So what about some pharmacologic options? So antispasmodics, you're probably all familiar with. So there's kind of two common ones we'll prescribe, dicyclomine or Bentyl, as well as hyoscine or Levsin. So these can be really helpful for treatment of pain, and this has actually been demonstrated better for really more mild pain. If there's more severe kind of chronic pain, I still steer more towards the neuromodulators. But in general, these can be very helpful for kind of more of the intermittent pain episodes. Just one thing to be mindful of is they do come with significant side effects of the anticholinergic side effects. So that can include like dizziness, dry mouth, blurry vision, drowsiness, constipation. So I kind of always counsel people about that. And also, because with our older patients, they may be at even more increased risk for having side effects, just kind of being mindful or thoughtful about prescribing this to our older patients. Another therapy that also has a lot of good data to support is the use of peppermint oil capsules. So this has been demonstrated to actually be beneficial for kind of all global IBS symptoms. And what happens is that the peppermint oil seems to help with smooth muscle relaxation of the intestines. And again, this has been demonstrated to improve both abdominal pain as well as global IBS symptoms. Usually counsel people to try to take about maybe 30 to 60 minutes before meals, but they can really kind of take it as needed, or sometimes have people take it before bedtime if they have no more nighttime symptoms. And then the one caution I also provide for patients when using this is that because it can also relax the lower esophageal sphincter, they may experience some increased heartburn. So there is this one brand, IV Guard, you may all be familiar with, that is encapsulated, has a special encapsulated formulation. So they're advertised that maybe there's a lower risk of heartburn with use of this. But honestly, I tell people getting the generic versions should work equally as well. So moving on to antibiotics, in particular rifaximin. So rifaximin has been very well demonstrated to be beneficial for pain, in particular for patients in irritable bowel syndrome and diarrhea. So how this works, this is a what we call a non-absorbed antibiotic. So something that we think is very gut selective, which is nice because as a result, there's not really much systemic absorption. I think 90-95% of the antibiotic gets processed by the liver, or metabolized by the liver during first pass. So again, very minimal systemic absorption, which is nice. So side effects are pretty uncommon. And this is a very well-tolerated medication in general. Usually we'll prescribe, so it'll be 550 milligrams, 3 times a day for 10 to 14 days. But kind of the limiting factor here is oftentimes cost because it is a very expensive antibiotic. So insurance oftentimes will not cover the antibiotic or they'll make you jump through many hoops to kind of get the antibiotic available for patients. So just keep that in mind. And you can consider breath testing to evaluate for patients for SIBO, which is the other indication for treatment of this disease, or for use of rifaximin, sorry. That can also be considered, but not necessary if you're using it for treatment of IBSD. So moving on to our other big category of medications are really the central neuromodulators. So why consider use of the central neuromodulators? So going back to the physiology, so the thought is that, possibly by using medications such as the neuromodulators, maybe you're treating some underlying psychiatric and brain gut disorders that can be associated with pain. So commonly, so using that kind of antidepressant, anti-anxiety effect to your advantage. There are some peripheral effects with these medications, so they can affect kind of motility as well as secretion within the intestinal tract, and as well as reduce nerve signaling from the gut, in particular with the TCAs. So it can really help with that visceral hypersensitivity or analgesia effects. They can also improve the brain's pain regulation, so really kind of helping how patients modulate and perceive pain. And they have been demonstrated to also enhance nerve cell regrowth or neurogenesis, and that could potentially lead to improvement or changes in the gut motility as well. So there's kind of multiple different classes of central neuromodulators that can be used in treatment for DGBI. And the selection is really based on kind of the clinical characteristics that you're trying to treat. And then that can help you select which category of the central modulator you might want to choose to treat for patients. So SSRIs I find to be not so great for pain, in pain-associated DGBIs, But in patients who you suspect maybe there's a very significant underlying component of like anxiety, depression, or maybe some phobic features, then SSRIs can be really effective for kind of co-management of that. For pain, though, really the first line treatment I find is going to be the TCA. So this is like amitriptyline, nortriptyline, imipramine, or desipramine. This in multiple studies has been kind of what we have found to be the most effective for treatment of the pain-associated DGBIs. Oh, sorry. Then you also have the tetracyclic antidepressants. So this is something like mirtazapine, trazodone. This can be really helpful for patients who have maybe more early satiety, weight loss, nausea, vomiting, or disturbed sleep patterns. And then you have your SNRIs, which also can be actually very effective for pain predominant DGBIs as well. In particular, in patients who maybe you're worried about the side effects of the TCAs, like if somebody who has maybe IBS constipation, you might be a little bit more reluctant than maybe considering SNRI instead. So to talk a little bit more about the TCAs, so these are the tricyclic antidepressants. Again, this is really, this class of drugs have been, I would say, the most effective for treatment of the pain predominant symptoms in patients with DGBIs. So this has been demonstrated in a number of studies now for helping to decrease global symptoms of patients who have irritable bowel syndrome. My general approach is always to start low and go slow. So by low dose, I mean starting with a 10 milligram dose, usually at bedtime, because again, it can have a common side effect of drowsiness. And then you really want to increase the dose pretty gradually. So a lot of the studies, they'll usually do at least wait at least 1 week before increasing the dose. But oftentimes I'll even tell patients to go slower and maybe even waiting 2 weeks to make sure they're tolerating the medication before gradually going up the dose. And oftentimes I just have them go up by 10 milligrams until they kind of reach more of like a 30 milligram dose. There's two subtypes of the TCAs. So you have your tertiary amine TCAs and your secondary amine TCAs. The difference here is really the side effect profile. So for the tertiary, this is more like your amitriptyline and imipramine. They're going to have more anticholinergic side effects. So think about, again, in patients who might be more prone to constipation, you may want to avoid, but would be great then for consideration in patients with IBS-D. Whereas your secondary amine TCAs tend to have less anticholinergic side effects. So this would be like your desipramine, nortriptyline. So this might be a really good option then for patients who may be a little bit more constipation prone. So this was a big trial that was done in Lancet, published in 2023. And this looked at as an RCT of use of the low dose amitriptyline, actually, so just 10 to 30 milligrams daily versus placebo. They had about 200 patients in each arm. And their primary outcome was looking at the IBS severity scoring system after 6 months of being on therapy. So you'll see her really looking at the effect here. So that after 6 months, there was a more significant decrease in the IBS score in patients who were on the low dose amitriptyline versus the placebo. So again, and this was a study that was done kind of across 5 different general practices within England and really demonstrated that this can have a significant favorable outcome, even just using low dose amitriptyline for patients with IBS. So what are some non-pharmacologic options that are available? So there's also this large category of what we call brain-gut behavioral therapies. And this was a nice systematic review and network meta-analysis of 41 RCTs that looked at various different types of psychological interventions. And you'll kind of see the range here. And whether or not this would be effective in helping patients with IBS. And they also found that with, in particular, cognitive behavioral therapy or CBT, as well as gut-directed hypnotherapy, seem to have the largest evidence for improvement in global symptoms for patients with abdominal pain in IBS as well. So something to consider in referring patients to see a psychologist who is GI trained and able to kind of work with them to develop these kind of coping mechanisms to help modify their pain. And then, oh, sorry, this is an old slide here. This is what I wanted to go on to. So what are some, if, again, because GI psychologists, unfortunately, can be hard to come by and a pretty limited resource. So there's not that many who have availability. Unfortunately, we don't have one at UC So then I look to other resources potentially provide for patients. So common one is usually using like a phone app. And there have been a number that have been designed and kind of come out in recent years for targeting patients who have IBS or other DGPI. So a few that I'll usually suggest to folks are here, highlighted here. So there's Nerva, Zemity, Mahada. Um, Keep in mind, a lot of the times these are not for free. So Nerva usually has like a 1 week free trial, but then it requires a subscription. So just I always kind of warn patients about that. But again, these have all been demonstrated in studies to be beneficial for patients with IBS symptoms. So moving on now to functional dyspepsia. So this will be a little bit briefer. So how do we diagnose people using the Rome 4 criteria for functional dyspepsia? So again, similar to IBS, they have to have had symptoms for at least 1 day per a week in the last 3 months with symptom onset starting 6 months prior. And they have to have one or more of the following symptoms. So postprandial fullness, early satiety, epigastric pain, or epigastric burning. And as part of the diagnosis, you want to make sure you've ruled out any evidence of structural cause. Oftentimes, this may involve, performing an upper endoscopy. In select patients, I also will consider a gastric emptying study if maybe there's some concern for underlying gastroparesis or delayed gastric emptying, but certainly not required for all patients. So for functional dyspepsia, we also can classify into two subtypes. And this is really helpful for management purposes. You want to distinguish between either the postprandial distress syndrome versus the epigastric pain syndrome. This is really characterized by what what symptom is predominant here. So the postprandial distress syndrome, or PDS, you'll see that they most often have kind of meal-associated symptoms. So it tends to be a lot of fullness, early satiety around eating and after meals. Versus the epigastric pain syndrome, usually the main complaint here is some sort of epigastric pain or burning, and this may or may not be related to meals. In both of these subtypes, you can also get symptoms of bloating, belching, and nausea. However, vomiting or in particular intractable vomiting is not typical or classic for this and would bring other disorders like cyclic vomiting syndrome or functional chronic nausea vomiting into mind. So what workup should be done in patients coming with dyspepsia? So what I just want to highlight here is not everybody needs an endoscopy. So this was a nice guideline from 2017, and they really highlighted kind of first breaking down patients by age. And so in patients who are kind of 60 or older, probably want to perform an endoscopy in all those patients, just because the risk for malignancy is going to be higher for this age group. So we really want to make sure that you're not missing some organic pathology here. But let's say if they're less than 60 years of age and they have no red flag or alarm features as well. So keep that in mind. If there's any alarm features, you do want to perform a procedure or endoscopy. But if there are no alarm features and they're relatively young, then just simply getting an age pylori test should be sufficient. And then if that's positive, obviously you will treat. And then if negative, kind of move down this algorithm here. So kind of moving on now to how we can treat patients with functional dyspepsia. Again, coming back to which neuromodulators you might want to consider. So depending on if they have postprandial distress syndrome, so really that's the more kind of early satiety, fullness when they're eating. The two medications here I really like are buspirone and mirtazapine, and both of these can be really effective. Buspirone, in particular, for kind of more of that early satiety, because the thought here is that it can lead to gastric accommodation, so leading to kind of more stretching of the stomach to accommodate the food when you're eating. Whereas mirtazapine is actually a really effective antiemetic. So I use this in more of my patients who have kind of more nausea, predominant symptoms related to the meals, as well as the early satiety. And also if they, as a nice kind of bonus side effect, it's an appetite stimulant and can help with weight loss or weight gain, sorry. So in patients who are struggling with weight loss, it's a good consideration too. So if they're more of the epigastric pain syndrome, though, on the other hand, again, TCAs are really going to be your go-to for here. You can consider the TCA even after, let's say, if the patient's done a PPI trial without symptomatic improvement, then really trying a TCA is a good idea. And then if they are not able to tolerate the TCA, or if there are other reasons why you want to avoid TCA, you could also consider SNRIs here too. So this is just a study that was done in 2016 to demonstrate that mirtazapine can be very effective again in patients with functional dyspepsia. So a pretty small study, just 17 patients in each arm with mirtazapine compared to placebo. But they did find at both week 4 and at week 8 that patients who were on mirtazapine had significant reduction in their dyspepsia symptom scores. So I know we have a few minutes waiting, so I'll try to go through just some common belching disorders that you'll see in clinic, just something to, just be aware of. And of course, do some additional reading on your own if there's more questions. So some common way to break down belching first is whether the patient you think is experiencing gastric belching versus supragastric belching. And why this is important kind of comes into why more commonly is going to be supragastric belching that you'll see. The gastrobelching occurs because there's an increased production of gases, and that this is then coming up and being belched from the stomach. Whereas supragastric belching is actually the patient is sucking in air into the esophagus from the pharynx and then belching. So it's really not gas coming or originating from the stomach. In this case, then the LES doesn't typically relax. And again, so the air doesn't reach the stomach. And classically, what you see is patients are complaining of very frequent, kind of repetitive belching. So even during the visit, sometimes I'll see them belching in front of me. And when that's occurring, I have a much higher suspicion this is going to be supragastric belching. So you can diagnose, you can just make this usually with a clinical diagnosis, but you can actually objectively diagnose this using a pH impedance test and manometry. So this is an example of impedance. So you'll see here on the left-hand side what you would expect to see in a patient who has supragastric belching. So this is characterized by this rapid rise in the impedance and then proximal veins initially. And then as you move distally, there's then this rapid return to baseline in the distal leads first, and then kind of moving proximally. This is in reaction to kind of that very rapid, quick gas expulsion, kind of just sucking into the esophagus and then rapidly coming out. Whereas in gastric belching, you'll see that the rise in impedance typically starts in the distal rings. So that's how you know then the gas is originating from the stomach and then kind of moves proximally. And that's reflective of this retrograde grade coming from the stomach going upwards into the esophagus of movement of gas. So this is, again, just a small study that looked at patients who were complaining of belching, and they found that really it was the supragastric belching in these patients with belching disorders that seemed to be the most predominant, most bothersome symptom. And so how can we treat this? So diaphragmatic breathing has been what's been best demonstrated for alleviation of their symptoms in belching disorders. I mean, you really use it for any of the common belching disorders. So something I commonly will teach folks. But this was a small study that was done in patients who had PPI refractory GERD and bothersome belching. So there's a high suspicion here, probably that there was either some supragastric belching, and that we knew this was not due to acid reflux, because 67% of these patients actually had evidence of reflux hypersensitivity on their pH testing. So the intervention was diaphragmatic breathing, which was taught by a speech therapist. And the comparator was just patients who were on the wait list. And they looked at the primary outcome of the decrease in the belching severity. And so they found here that 60% of patients had a greater than 50% reduction in their belching severity during this 4-week period, compared to essentially 0% of patients on the wait list. So again, diaphragmatic breathing can be really helpful. Usually it's something hard to kind of teach patients during the clinic visit. So usually I'll give the patient some really brief explanation that these are kind of like deep belly breathing exercises that kind of help calm your vagal nerve tone, as well as kind of calming the abdominal wall muscles. But what I'll usually do is include a YouTube video. So just some examples of how of various speech therapists who do teachings on how to perform the diaphragmatic breathing, and that can be really helpful for patients to review later. And usually the counseling is you want them to do this for working up to the goal of like 5 to 10 minutes at a time, and usually performing this kind of throughout the day. So the goal is to do this maybe 3 or even 4 times a day. And what about the physiology for bloating as well as abdominal distension? And this is really just to kind of distinguish between bloating, which is really the perception or sensation that the belly is larger or tenser, versus actual abdominal distension. And this is just to highlight that patients truly, in those who are have the sensation of bloating, also develop changes in their abdominal wall and as well as abdominal distension. And so this is a small study, again, where they induce colonic gas infusion in both healthy controls and then patients who are complaining of bloating disorders. And they did find that in the red, this is the patients who are patients who experience the bloating versus the green controls, that they did objectively have this increase measurement in their abdominal girth when they were infused with the colonic gas. So there is a change in their abdominal distension here. And this can be explained in part by this phenomenon called abdominal phrenic dyssynergia. And so what happens here is that patients with bloating or experiencing bloating, they have a different muscle response when there's this infusion of abdominal gas. And so in a normal gut here, when you have an increase in the gas production within the gut, what should happen is that your diaphragm should ascend, relax, and basically rise up, and the abdominal wall muscles should contract to kind of maintain that flat belly. But in patients who have this abdominal phrenic dyssynergia, essentially the opposite happens. So rather, the diaphragm then contracts and descends, and then the abdominal wall relaxes, and that allows the abdominal wall to kind of pooch out and develop the distension that the patients will perceive and see. And this is just a study on the left, kind of also highlighting the fact that you, again, see this change in both the diaphragm as well as the abdominal wall muscles during this response. So treatment, again, usually for this issue is the diaphragmatic breathing has really been best demonstrated for alleviating the symptoms. And then lastly, just some basics. So other considerations to keep in mind. So kind of common differentials I'll think about in my patients who I'm seeing with bloating. So if there's potentially some other underlying causes. So if there's dietary factors, again, if there's some reason for why there's increased gas production from certain foods that they're eating. So you may want to consider certain diets. Again, kind of we briefly talked about like the low FODMAP diet, but also maybe just cutting out lactose or fructose can be common ones that can be very helpful. But if they're actually constipated, and that's the underlying problem, then treatment with laxatives or even biofeedback and pelvic floor therapy can be more beneficial in this case. Keep in mind SIBO, something very common again. And so maybe performing that breath test or just empirically treating with rifaximin. Also, if there's risk for hypersensitivity, so again, there's that sensation component of the bloating, in addition to the distension, then considering the neuromodulators here. And then again, for the abdominal phrenic dyssynergia, diaphragmatic breathing is really what's been best demonstrated. All right, I think that's all I have for you. I know that was kind of a whirlwind of kind of common DGBI disorders that you'll see in clinic and a review of how to manage them. But yeah, happy to take any questions at this point and then go from there.